Good morning, everyone. Today we are going to start with the new topic, that is hematinics. Okay, so let's move forward. So, hematinics, what are the hematinics? These are the drugs which are involved in formation of blood, and thus they are used in treatment of anemia. Okay, so we have already studied everything about the anemia. So it is a condition in which the blood is deficient in the number of RBCs, that is the erythrocytes, in or the hemoglobin, or there is deficiency in quality and in the quantity of the blood. Okay, so what we observe in anemia is that either there is a lack of RBCs, or there is decreased in amount of hemoglobin in each RBC, or there is deficiency in quality and quantity of the blood. Okay, so the erythrocytes, what function they play? They are responsible for the delivery of the oxygen to the tissues. So it clearly means that if there is less number of RBCs, there is less amount of oxygen which is reaching to the tissues. So same thing we can say about the hemoglobins also. So in case of hemoglobins, they are the actually main part of the RBC that is responsible for binding to the oxygen molecules. Okay, so if hemoglobin is less, then oxygen carrying capacity of the blood is also less. Okay, so there are four types of the anemia. So the first one is the microcytic anemia. As the name suggests, microcytic, micro means small. The cell size, the RBC cell size is small, and this happens due to deficiency of iron. Okay. Then we have second type of anemia, that is macrocytic. Okay, macro means big, big cells. The cells are very big in size, and we have already studied the type of it, that is megaloblastic anemia. Okay, and it happens due to the deficiency of folic acid and the vitamin B12. Then we have third type of anemia, that is hemolytic anemia. As the name suggests, lysis of the RBCs. Okay, so this can happen due to variety of reasons, and the breakdown is abnormal. Otherwise, the RBCs they also get breakdown, but that happens in spleen, and that happens due to they have reached their lifespan, that is of 120 days. Okay, then we have fourth type, that is aplastic anemia. So in this case, the body stops producing the new blood cells, and where the new production of the blood cell happen, it happens in the bone marrow. So anything, any disease that affects the red bone marrow, then it is going to end up causing the aplastic anemia. Okay, so uh, as we have studied now that there are four types, but out of these four types, the first two types, they we can actually do something about them. Okay, and that's why we have only three drugs which we can use as the hematinics. That is, the first one is the iron, second one is the folic acid, which is also known as pteroyl glutamic acid, and the third one is the vitamin B12, that is cyanocobalamin. Okay, so we have studied the types of anemia, so you have to remember it, that the pathophysiology of anemia. So we, in that first we had studied about the iron deficiency anemia, second we have studied about folic acid and or vitamin B12 deficiency anemia. So as there is a deficiency of these constituents, we provide them externally, so that that deficiency is compensated. Okay, So let's start with the iron first. We will finish the iron deficiency first, and then we will consider the other two, that is folic acid and the vitamin B12. Okay, so the human body, it contains about 3.5 grams of iron, so of which about two-third is contained in the blood. Okay, so this is all general statistic about the iron. So out of ingested iron, the 5 to 10% is absorbed, and once it is ingested, the acid in the stomach, it has multiple effects on this ingested iron, like the one that is it aids in ionization of the iron. So the iron splits chelated food iron from the chelator. Okay, so this acid, it splits the chelated food iron from the chelator. Chelator is like complexing agent. Okay, so it maintains iron in soluble form. And next is the it allows the iron to remain in the absorbable form, that is the ferric, that is Fe3 plus. Okay, so that is what acid does to the iron. Okay, so the sources, from which sources we will get the iron. So sources as mentioned, that is meat, chicken, egg yolk, liver, fish, oysters, wheat germ, then dry fruits, then dry beans, spinach, yeast, bananas, apples. They are the rich sources of iron. However, milk and root vegetables, they have very poor amounts of iron. Okay, so the iron in meat protein is helpful in efficient absorption. The hemoglobin, it consists of heme iron and the myoglobin, which can be absorbed completely as hemine. Okay, so hemine is ferric form of heme without being broken down into the elemental iron. Okay, so in other foods, the iron is less available for absorption. The reason too is that it is bound to the phytates or other complexing agents. So it becomes really difficult to break down the bonds between the iron and these complexing agents. Otherwise, in some cases, these bonds can be broken down with the help of acid in the stomach. But it is not always possible to break these bonds and release the iron that can be absorbed. Okay, so non-heme iron and inorganic iron salts, that can be absorbed by intestinal mucosal cells only after getting converted into the ferrous iron. Okay, so next is mechanism of iron absorption. So the iron absorption, it occurs all over the intestine. In stomach, it which contains the hydrochloric acid and a reducing agent, it converts ferric to the ferrous form. Okay, two separate iron transporters in intestinal mucosal cells, they function to effect iron absorption. So which are these two iron transporters? At the luminal membrane, we have divalent metal transporter 1, that is DMT1, which carries ferrous iron into the mucosal cell. Okay, so the ferroportin, the second transporter, which are bound with the ferrous iron, and it pass through the mucosal cell directly into the bloodstream. Okay, so we have two transporters. One transporter is DMT1 and other transporter is ferroprotein, ferroportin, not ferroprotein, it is ferroportin. Okay, so this DMT1, it is present at the luminal membrane, and the ferroportin, it is directly passing through the mucosal cell and it delivers the iron to the bloodstream. Okay, so next we will see one short video related to this, so that you will have more understanding how it gets transported across the gastrointestinal membrane. Okay.
Iron is an essential trace element necessary for numerous biochemical and cytophysiological processes. Meat, seafood, and poultry contain both heme and non-heme iron. Iron in plants, iron-fortified foods, and iron supplements contain non-heme iron. Both forms of iron are released from your food matrices by proteases in the stomach and small intestine. The bulk of iron absorption occurs in the proximal small intestine. Iron absorption starts at the apical flesh-border membrane of the epithelial cells of the intestinal urethra. Here, there are two separate processes for the intestinal absorption of heme and non-heme iron. Heme iron transport begins with heme binding to a heme receptor located in the flesh-border membrane. Receptor-mediated endocytosis results in the internalization of the heme receptor complex. An endosome fuses with the vesicle, protons are pumped into the fused endosomal vesicle, and the heme is released from its receptor as the vesicle becomes acidic. Heme oxygenase within the endosome catalyzes the removal of iron from heme. The iron remains in its reduced ferrous state as it is transported out of the endosome by the DMT1 duodenal metal transporter 1 iron transporter. The reduced ferrous iron in the cytosol becomes part of the labile iron pool, which contains iron-dependent enzymes and iron-binding proteins. Non-heme iron is in its oxidized ferric state and must be reduced prior to its transport. D-site B, duodenal cytochrome B, has ferric reductase activity and reduces the ferric iron to ferrous iron. The DMT1 transporter then transports the reduced iron across the flesh-border membrane. The reduced iron is then added to the labile iron pool. If the person's iron status is elevated, then the iron can be stored in ferritin, where it becomes oxidized as part of a ferric hydroxide phosphate crystal. Iron not bound within the labile iron pool, or ferritin, will be transported across the basolateral membrane. Ferroportin 1 transports ferrous iron out of the cell. Iron is oxidized by hephaestin and binds to apotransferrin for transport in the portal circulation. Iron bound to transferrin is also transported into the intestinal cell at the basolateral membrane. The holotransferrin binds to the transferrin receptor and is taken into the cell via receptor-mediated endocytosis. The vesicle fuses with an endosome. The vesicle becomes acidic and the transferrin releases its ferric iron. The released iron is reduced by STIAP, 6-transmembrane epithelial antigen of prostate, and transported across the endosomal membrane by DMT1. It then enters the intracellular labile iron pool.
Okay. So that was everything about the absorption of the iron. So we have seen that how by different means the iron is being transported across the gastrointestinal cell membrane, and what are the different types of transporters. Okay, so although it is a very complex process, as we have seen into that particular video, but it is not expected from your side that you should remember each and every part of it. Actually, uh, I have less complicated that particular part of the absorption, and only important things, only important transporters I have mentioned over here. Okay. Otherwise, if you want to read more about the absorption of iron across the gastrointestinal membrane, then you can read it from the any of the book like Katzon or Goodman and Gilman. It will give you the thorough understanding that how iron absorption occurs. Okay. So next part is the transport, utilization, storage and excretion of iron. So, as such, on entering plasma, it is immediately converted to the ferric form and is thus complexed with a glycoprotein which is called as transferrin. Okay, that is TF. Okay, so iron is transported into erythropoietic and other cells through attachment of transferrin receptor, that is TFRs. So the complex is engulfed by receptor mediated endocytosis. So once it is engulfed, the ion dissociates from the complex at acidic pH of the intracellular vesicles. So the released ion is utilized for hemoglobin synthesis or other purposes. And what happens to the TF and TFRs? They get returned to the cell surface to carry the fresh loads. Okay. So next is, this is the diagram which indicates that how absorption of dietary iron happens. Okay, so we have the three forms of it, that is the Fe3 plus, Fe2 plus and the Hem1. Okay, so that why I am saying that three forms, because sometimes the Fe3 plus, if it is present, it needs conversion to the Fe2 plus. Okay, and sometimes we directly get the Fe2 plus, and in that case, if the ultimate uh, transporter that carries the Fe2 plus, it is DMT1. Okay, and if we have the heme, then we have to take out the Fe2 plus out of the heme, and this taking out of Fe2 plus from the heme, it happens in the mucosal cells. Okay, so this Fe2 plus is then transported by the ferroportin 1, and it causes its entry, the Fe2 plus entry into the plasma. Okay, so once in plasma, it binds to that transferring a glycoprotein, and it thus transported to the locations where it can be utilized. Okay, so next is the storage. So the mainly the this Fe2 plus, it is ferrous. It is stored in the reticuloendothelial cells, then spleen, then bone marrow, and the hepatocytes and myocytes. So these are the major storage areas for the iron. So the therapeutic uses of iron in a treatment of the iron deficient anemia. Second is in pregnancy. Then third is in premature babies. Then fourth is the in case of blood loss. Then next is hookworm infection. Sorry for that. It is not N, it is M. It is hookworm infestation, which is a type of helminth. Okay. Then next is in treatment of malabsorption syndrome. Malabsorption syndrome means in which the absorption of the iron, it is abnormal. Then uh, in GI bleeding, which happens due to the ulcerations, then excessive intake of the aspirin, and also the excessive consumption of the coffee. Okay, so preparations of iron. So we give the iron, we use the iron for multiple therapeutic uses, but in what dosage forms we have the iron? Okay, so we have oral iron preparations and the parenteral iron preparations. So the oral iron preparation, various forms of it we have. We have the tablets of it, we have the capsules of it, and in case of parenteral iron preparation, we can give iron preparation by the intramuscular route or the intravenous route. Okay, so oral iron preparation. So it is most common and it is a preferred route for iron therapy. Simple as that, because the compliance of the patient is better with this, with oral iron preparation rather than parenteral ones. So the dissociable ferrous salts, they have high iron content and it can be absorbed more readily than the ferric salts. Okay, so iron salts are mainly used in tablet form as their solution forms stain the teeth. So solutions, any syrups, they are avoided. Okay, so tablets which we have over here, you can see onto the right side in the table, ferrous sulfate hydrated form. So how much dose we have, that is zero point 0.3 gram, that is TID, that is 3 times a day. Then ferrous sulfate excited form, that is zero point 0, zero point 0.2 gram, again 3 times a day. Then we have ferric ammonium citrate form, we have to give 1 gram 3 times a day. See that how much quantity is increased when we change the that particular form from ferrous to the ferric. For ferrous it was only zero point 0.3, but when we have uh, shifted to the ferric form, the dose increased to the 1 gram directly. Okay, then we have reduced iron form, that is zero point 0.5 grams 3 times a day. Then we have ferrous gluconate form, that is zero point 0.6 gram 3 times a day. When we have ferrous fumarate form, we have zero point 0.2 grams 3 times a day. Then we have ferrocholinate form, again zero point 0.5 gram 3 times a day. And the starred ones, they are the most commonly used forms of the oral iron preparation. Okay, so the available slow release and chelated iron formulation, they cause less gastrointestinal upsets and are better tolerated by the children. So we have to use these slow release and chelated iron formulations when we have to give the formulations to the children. High dose therapy for long time, it leads to hemosiderosis. So hemosiderosis, it is an adverse effect which we observe when we give the iron in high quantities for prolonged duration of time. The next, parenteral iron preparation. Generally, oral iron therapy is enough to cure anemia, and the parenteral therapy is needed only in critical cases such as intolerance to the oral therapy. Then, improper iron absorption from the intestine. Then, malabsorption syndromes. Then, inadequate response or severe iron deficiency anemia. In such conditions only we have to give parenteral therapy, otherwise we have to avoid it. Before the beginning of the therapy, the total dose to be administered parenterally, it should be calculated, and it is based on the hemoglobin level, and there is a formula to it, which is total dose in milligram is equal to 4.4 into body weight in kilograms into hemoglobin deficit in gram per 100 ml of blood. So how to find out that hemoglobin deficiency in gram per 100 ml of blood? Simple, we have done the Sahli's method to determine the hemoglobin. So by that method we can easily determine that how much gram of hemoglobin is present in 1 deciliter of blood. So you we have to just convert it to the 100 ml and we will get the gram value of the hemoglobin, and we get to know that how much gram of hemoglobin is deficient in 100 ml. Okay, so from that we can get this value. So intramuscular preparation. So we have the iron dextran injection. It is branded. Brand name is the Imperon. Okay, so is commonly used intramuscular preparation, which contains 50 milligram per ml of the elemental iron. So daily 1 to 4 ml of the injection is administered through deep intramuscular route using Z-track technique, which is nothing but a way of applying intramuscular injection which prevents tracking or leakage of medication into the subcutaneous tissue. Okay, so it assures that entire contents of the injection they will remain in the muscle only. They won't get into the subcutaneous layers. We have next, that is intravenous preparations, and these preparations are free of preservatives. The first dose should be limited to 25 milligram and it should be gradually increased to the 100 milligrams per day. Okay. So therapeutic uses of the iron, they include mainly used in treatment of iron deficiency anemia, which results due to severe or chronic hemorrhage, malabsorption syndrome, then simple achlorhydria. Achlorhydria is the condition in which there is decrease in the amount of HCl which is getting secreted in stomach. So as we have studied that what this why we need the acidic condition in the stomach, actually it aids the or it helps in the absorption of the iron. So if there is condition of achlorhydria, then iron absorption will be impacted. So we can call such condition as the malabsorption syndrome. The next is the malignancy. Then in case of infection, then nutritional deficiency. Nutritional deficiency is straightforward. When whatever food we are having, if it is deficient or if it doesn't contain enough amount of iron, then it creates the nutritional deficiency of it. Then in case of pregnancy, where the amount of iron which is required by the body, it increases, so it creates the condition of iron deficiency and it can be rectified by giving the iron therapy. Then in case of lactation, again the demand is increased, so we have to match the demand by increasing the supply. Then in parasitic infestation like the hookworm infestations. Okay, so these hookworms, these helminths, for their growth, for their survival, they are dependent on your body. So they cause this iron deficiency. Okay, so iron deficiency anemia, it responds to iron therapy quickly. However, the given cause should be treated concurrently. Okay, so even if the hemoglobin level becomes normal, the iron therapy should be continued for replenishing the exhausted stores of the iron. So we should not stop it once the hemoglobin level becomes normal. We have to continue with the therapy. Okay, so with the uh, beneficial effects of the iron, there is a toxicity of the iron is also observed. Okay, so we can divide the toxicity of iron into two, that is the acute and the chronic. So first we will see the acute toxicity of iron. So acute toxicity, the it will happen because of excessive intake of iron salts. Then adults can tolerate large doses without any problem, but the doses of 1 to 2 gram of iron, it can be fatal to the young children. That's why we have to be careful with these iron tablets. If these preparations, if they get into the hands of the children and if they have it, then it will create the acute toxicity. And the symptoms of this acute toxicity include the abdominal pain, vomiting, and diarrhea, which is followed by shock. Shock, we have already studied the cardiovascular shock, lethargy, pallor, and the cyanosis. Cyanosis is lack of or deprivation of the uh, tissues of the oxygen, and it can be seen as the bluish coloration of the skin. Okay, so these signs and symptoms of the acute toxicity, they appear within 30 minutes or sometimes later. In case the patient survives for 6 hours, then it can be passing period of recovery, which is followed by death within 12 to 24 hours. Okay, so understand this particular iron toxicity is a very uh, fatal kind of condition, and it needs to be treated on emergency basis. So the treatment of acute toxicity, it includes the emergency therapy needed, and it includes the gastric lavage. Okay, gastric lavage means what? We have to wash the contents of the stomach with phosphate or carbonate solution to produce insoluble iron complexes. Okay, so the iron chelating agent, that is the deferoxamine, it should be infused parenterally in the stomach so that it binds to the iron in blood and improves its excretion. Okay, supportive therapy is given in case of shock, dehydration, and acid base abnormalities. Then we have the chronic toxicity. It is the condition in which excessive iron is deposited in the heart, liver, pancreas, and the organs, and thus it is known as the hemochromatosis and the hemosiderosis. Okay, so this ultimately leads to organ failure and the death. The hemochromatosis is an inherited disorder in which absorption of iron increases abnormally. For treating iron toxicity, deferoxamine, the same chelating agent, is used, but it is less satisfactory and is costly. However, it may be used in conjunction with the phlebotomy. Okay, so phlebotomy is like bleeding procedure. Okay, so we can we can what to say, we can replace the phlebotomy with other thing, that is use of leeches, you know, जळू ज्याला म्हणतात. Okay, so we can use leeches for the bleeding purpose. Okay, so with this we have finished with the first part of the hematinics, that is the ions. Okay, so the next part of hematinics we will study in next lecture. Till that time, that's all from my side. So, thank you.